I congratulate Dr. Suresh and Dr. Parul for initiating this program, this wonderful program. So we'll be starting with the first talk, Understanding the Basics of A-Scan Biometry by Dr. Ujjwal.
To Dr. Suresh sir and Dr. Parul ma'am for giving me the opportunity to present at this PG teaching program. And I'll be talking about the basics of A-Scan Biometry. To begin with a little bit of historical perspective, so in 1949 when Harold Ridley implanted the first IOL, he had a refractive surprise of nearly 20 diopters. In 1970s, more accurate A scans were available and several studies were done to establish theoretical Vergence formulas. Till date, these formulas have been subjected to minor and major alterations in variables. The axial length can be defined as the distance from the anterior corneal surface to the retinal pigment epithelium, and it is measured using optical or ultrasound methods, which can be further of direct contact or immersion methods. It is the most important parameter in modern day formula because any change in the IL power by nearly 2.5 to 3 times can be derived due to any error in the measuring of axial length, and this is more so in short and long eyes. The most commonly talked about formula is the SRK, and by that I mean Sanders, Retzlaff and Kraft, who gave us the formula P power of the lens is equal to A constant minus 2.5 times the axial length minus 0.9 times the mean keratometry. It has now been replaced with newer generation formulas, but it's still useful for understanding the relationship of the variables. So how do we measure the axial length? So we have different methods available. The first is the ultrasonography method or the contact method. Under this we have the applanation method. We can see the image over here. It's much like a Goldman applanation tonometry, but it's not very commonly used. Then we have the contact method, which is the handheld method with a probe, and then we have the immersion A-scan method. Under the optical methods, we have the Zeiss Humphreys IOL Master and the Lenstar by Harkstreet. So these are non-contact methods. So what is the principle of A-scan? So it uses mechanical waves to calculate time needed for a pulse to travel from the cornea to retina. Now sound travels with different speeds as per the media, and the interface is the junction between any two media of different densities and velocities. So the spikes that we get in the A-scan are because of the interface of the anterior corneal surface, the aqueous anterior lens surface, which produces the second spike, the posterior lens capsule and the anterior vitreous interface, which produces the third one, the posterior vitreous and the retinal spike is because of this interface, and lastly the choroid anterior scleral surface interface produces the fifth spike. This is followed by a retroorbital short spikes due to the orbital fat. So in A-scan, the parallel sound beam is emitted from the probe tip with an echo bouncing back into the probe as the sound beam strikes different interfaces. This is then converted, the distance is derived by the time and the velocity. So A-scan is a one-dimensional display in which echoes are represented as vertical spikes from a baseline. In ophthalmology, most A-scan and B-scan probes use approximately 10 billion hertz, which is pre-designed by the manufacturer. So how do we do? This is the procedure for the contact method. Always explain the procedure to the patient before you start the procedure. We can numb the eyes using topical anesthesia like Paracaine. We have to clean the probe always before we use the A-scan probe. It is placed on the patient's cornea as shown in the diagram, in the image, and the operator must aim the probe towards the macula of the eye. This is important because if the probe is aimed towards the optic disc, then we will not get the retroorbital spikes, and that means it's an erroneous reading which needs to be discarded. So the alignment with the optical axis will be indicated by high lens spikes, then high retina spikes followed by scleral and descending orbital fat spikes. So this is another image showing the contact method at our hospital. It is the handheld method. So how do we interpret the contact method or A-scan graph? So the data can be entered into the system. We can enter the keratometry values over here, K1 and K2. As you can see here, the first spike is because of the cornea. The second one is because of the anterior lens surface. The third one is because of the posterior lens capsule. Then we have a flat vitreous face, and then the retina shows a spike which is very sharp, followed by a scleral and then retroorbital spikes. Besides this, we also get data of anterior chamber depth, the lens thickness, and also the vitreous cavity length from the A scan. The actual length can be displayed here. The IL power can then be calculated by the different options available. The gain can also be increased according to the media or the density of the cataract. So the ideal A scan, it measures, so if you're perpendicular, your graph will show equal double corneal peaks. There will be 5 high sharply rising echos. There will be descending orbital fat behind the scleral echo, and it will be a reproducible reading. So if you take multiple readings, they have to be approximately the same. There are different modes in A scan that are available. So you have the normal mode, then you have the dense mode, for which you can use for dense mature cataracts. There's the aphakic mode, which you can use for secondary IOL implantation. Then you have the pseudophakic mode, which also has further options according to the type of lens that is implanted. PMMA, silicon and acrylic mode. This can be used for the IOL exchange surgeries that you are planning. And then lastly, you also have the silicone oil fill method. So the contact method has disadvantages. As the probe touches the cornea, it can result in corneal compression and resulting in a shorter axial length. So this can be solved by the immersion A scan method, which is more accurate as it eliminates the corneal compression and is shown to be superior to the contact biometry. It is now accepted as a gold standard in most institutes. So this is what the immersion A scan looks like. It has this Prager shell or the immersions shell here. Now the probe is inserted inside the shell over here. There is a mark over here. It is important to keep the mark and the probe at the same level, because if this advances, the reading will be erroneous. Once it is at this level, it can be tightened with a knob over here, which can fix the probe. Now this is a short video showing the procedure. The patient is made to lie supine. The cornea is anesthetized with Paracaine. Then the fluid is injected and a water bath is created. And once that is done, the readings are taken. So how does the immersion A scan graph look like? It is slightly different from the contact method in that the first spike here would be because of the probe and the aqueous water bath. The rest of the graph is same as the contact method. Now I'll just describe a few scenarios of A scan. This is a mature cataract. So here generally what we have to keep in mind, if the spikes are not of good quality, we can increase the gain and then we can use this also in the dense mode. A scan in pseudophakia, this will show this single spike because of the lens. This is a 4-year-old child who was planned for secondary IOL. So in this you can see here there is no lens spike in the vitreous cavity. All the readings and anterior chamber depth are all 0 here. And in such cases it is better to cross-check the axial length by another method. So here we use the B scan to cross-check the axial length, and it was pretty much similar to the axial length by the contact method. This is another scenario of the A scan in a retinal detachment case. Here you can see 2 spikes in the mid-vitreous. So this is what it will look like in a case of retinal detachment. This was another case of cataract. We were doing workup and we found that there was a spike in the mid-vitreous cavity, and when we did a B scan, it was confirmed to be a PVD. Now A scan in silicone filled eyes can be tricky because the true axial length is often unknown and the measured axial length is greater than the true axial length. So in such cases, we can multiply the measured axial length by a conversion factor of 0.71. So this is how we can derive the true axial length in a silicone oil filled eye by the contact method. But studies have been done to compare the IOL master and the A scan biometry in silicone oil filled eyes, and they have found that the IOL master overall has more accuracy and less deviation in predicting the post-operative refractive errors. So if you have the option of IOL master, it's preferred to take that. There are other applications of A scan as well. It's used in pediatric cataract surgery, in keratoprosthesis surgery. If an aphakic K-pro is being planned, the axial length of the eye is measured by an A scan. Coming to the optical methods, we have the IOL master and the lens star. At our institute, we use the lens star method. The principle is partial coherence interferometry, and it uses light rather than sound to measure the axial length, the corneal radius, and the anterior chamber depth of the eye. So this is the image of the lens star. The patient is made to rest their chin on the chin rest, and the rest of the readings can be taken. The patient must be cooperative enough to fixate well, and we can take the readings, and from this graph we can choose the different types of IL powers and also the type of lenses. So the IL master, however, has its own limitations in dense cataracts, in hazy medias, and in patients who are unable to fixate. It does not give very accurate readings, or sometimes it does not give a reading at all. So whenever in doubt, we can use a combination of techniques. B scan can be used to confirm the axial length if you have a questionable A scan, which can improve the accuracy. The IL master is superior in cases of posterior staphyloma and in cases of silicon-filled eyes. So to summarize, for immature cataracts, we can use all these options, but immersion A scan and optical biometry can be preferred. For mature dense cataracts, immersion A scan would be the method of choice. Silicon-filled eyes and posterior staphylomas, optical biometry would be the better option. And in pediatric cataracts or in doubtful cases, it's always better to use a combination to confirm the axial length. So the take-home message would be contact ultrasound measurements have been the gold standard, but can have subjective errors due to corneal compression. Immersion measurements, they avoid corneal compression but have less control over alignment, so they can give varied results. The optical methods have benefits of non-contact procedures along with greater accuracy, but sometimes in dense cataracts they can give us false readings or they are not possible. So overall, combination of techniques can be used. Thank you.